So that's kind of the long and the short of how the ion transport happens in the kidneys. I think you'll agree it's kind of a beautiful system, right? I mean, it really is a fascinating thing that happens. Well, another fascinating thing that happens is acid-base balance. So just to refresh your memory, and I don't want to bore you, but remember that the pH is a logarithmic function, right? If we were to calculate the concentration or measure the concentration of hydrogen ions, it would be 0.0000004 equivalents per liter. Well, we can't do that. That's too much. Like, I can't keep track of all those numbers. I can't keep track of 4 kids. How am I going to keep track of all that stuff? So we use a logarithmic function and change that into the log of hydrogen, the negative log of hydrogen ions. All right. And that's just an easier thing for us to do. So we define the pH, or the potential hydrogen, as the pKa plus the log of the bicarb divided by H2CO3, or carbonic acid. All right. And this ratio exists in a 20-to-1, 20 bicarbonate ions to 1 carbonic acid. When we do all the math, plug all the numbers in, we come up with an ideal pH of 7.4. I don't expect you to know the math. I didn't even do the math here. I didn't show you any of the math. I just showed you the formula. This is how we do it. And at the end, we get the pH, normal pH 7.4. Okay? Now, what does 7.4 mean? Well, on this scale, this balance scale, we can see a couple things that we've already talked about. One is the pH of 7.4, right? And the range, because, we're not perfect, right? Nobody's perfect. The range of normal is 738 to 742. But if we're going to pick a perfect number, it's 7.4. That's the perfect pH. The other thing that we recognize here that we just talked about is this 1 part carbonic acid to 20 parts of bicarbonate. So this is the balance that makes all of this work. 1 part of carbonic acid, this is the acid component, to 20 parts of bicarbonate, which is the base component. And when those things are in equilibrium, we have a nice normal pH of 7.4. But when we stop breathing so much, or when we have a metabolic process, the acidemia happens. Just to clarify, if you're on rounds at the ICU at Penn, like I used to be, and you get asked about the acidosis or acidemia, the number that you're talking about in the blood, that is acidemia. When we're talking about what's going on in the blood, the presence of acid in the blood is acidemia. Once you do all the figuring and you come up with the diagnosis, that is metabolic acidosis, right? Once you attach the other word to it, it goes from being acidemia, which is what you see going on in the blood, to acidosis, which is the clinical condition associated with acidemia. Okay. That's just one of those things that you don't want to get embarrassed by using the wrong terminology. So again, if there's some decrease breathing, which builds up the CO2, which is an acid, that's going to push you from here over into the acidemia category. If there's buildup of lactic acid or acetylsalicylic acid, if you're poisoned, then that puts you over here in the acidemia category as well. All right. And if you blow off too much CO2 or you have too much bicarb, that puts you over here in the alkalosis world. And notice that once you get past a pH of 6.8, you're just dead. Like, that's unrecoverable. And a pH greater than 7.8, dead. So these are the things that your body relies on in order to maintain this acid-base balance. Now remember, there are buffers that float around in the bloodstream. Those are immediately available. So there's some carbonic acid and there's some bicarb that floats around in your bloodstream. Those are immediately available for your body to use to address acid or base discrepancies. But they're used up immediately, and to remake them takes days. It takes days. The lung component, which is CO2, right? Blowing off CO2 or conserving CO2, that happens within hours. That's an easier thing for your body to handle. But the kidney component takes days to reproduce that bicarb. And you know that process that it gets bicarb, I just showed you in the last, or a couple of slides ago. So the buffer is immediate. It's a function of the concentration of bicarb plus the acid in the blood. That is the concentration of hydrogen ions. That's in equilibrium with H2CO3, which is carbonic acid. And then through this process that uses carbonic anhydrase, right? This is an enzyme that catalyzes this reaction. It takes this carbonic acid and converts it into CO2 plus water. This is one of those metabolic processes that produces water. When you add carbonic anhydrase to carbonic acid, it makes CO2 plus H2O. Okay? Carbonic acid gives off hydrogen ions to make blood more acidic. And it does this process to take up hydrogen ions. Okay? All right. The lung component, again, when hydrogen ion increases in the blood, the chemoreceptors in the brain are stimulated. That makes you hyperventilate, blow off CO2, which also is an acid, and that makes the blood less acidic. The PaCO2, that's the partial pressure of arterial carbon dioxide, tells us how well the body is excreting carbonic acid, essentially, right? Because when there's enough carbonic acid, that affects the breathing rate and the loss or the gain of CO2. And then finally, the kidney component takes days, requires functioning kidneys. One of the things that lets us know that we need to get our patient to dialysis is whether they are acidemic. So when you have metabolic acidosis that's persistent and unfixable, no matter how much bicarb we give, that's an indication that the patient needs dialysis. Why do they need dialysis? Because their kidneys are broken, right? So remember that that bicarb requires functioning kidneys. To make bicarb, it requires functioning kidneys. Remember that for every hydrogen ion secreted into the renal tubule, one bicarb ion is reabsorbed into the blood. This is an efficient system, but by no means a super fast one. And that's why it takes so long for this balance to occur. And it can be easily overwhelmed. So in salicylate poisoning, for instance, the real issue is acidosis, right? These patients become acidotic and their kidneys can't make up time fast enough to be able to produce enough bicarb ions. All right. So in summary, you can see it summarized here. CO2 is transported in dissolved. It's dissolved as PCO2, about 7% of it. About 23% is carboxylated hemoglobin, and then the rest of the CO2 is present in this bicarb ion. Okay. The red blood cells participate in this process as well, as do the kidneys and the lungs to maintain acid-base balance. And you can plot all of this stuff with this graph. So here we have on the y-axis arterial plasma concentration of bicarb ions. On the x-axis, we have the blood pH. And then on these red lines, we have the concentration of dissolved CO2, the PaCO2. And so if I have a PCO2 of 40 and I have a, oops, dang it, sorry. So we have a this thing bothers me so much. Sorry, I have this magic mouse that I'm doing this on my computer with, and it's annoying. So here is a PCO2 of 40 along this red line, PCO2 of 40, and that would give this patient a a bicarb of 34 with a pH of 7.5. So I can use this to calculate exactly where it is. But there's other ways to do it too. This gives you one of those ways that helps you to think this process through. I'll let you look at that on your own. But I want to get to this part where I tell you about the marching metabolics. If everything goes wrong and you're stuck on rounds and somebody's pointing at you, waiting for you to tell the group whether, what kind of acid-base abnormality someone has, here's the way to cheat and figure it out quick. When the pH and the PCO2 go in opposite directions, that's a respiratory process. But you start by looking at what the bicarb is doing, because it's the last to change. If the bicarb is going in the same direction as the pH, that is a metabolic process. So if the pH goes down, that's acidosis, right? So this is a metabolic acidosis, when the bicarb goes down and the pH goes down. It's metabolic alkalosis if the pH goes up and the bicarb goes up. Okay? So the marching metabolics are what I refer to this as. And I can easily tell in somebody with acute acid-base abnormality what's going on here. I can tell that this is a metabolic process because the bicarb is going in the same direction as the pH. Okay? So when you evaluate these acid-base abnormalities, start with the knowledge that a perfect pH is 7.4. If the pH of the patient is 7.42, it's an alkalotic process. If the pH of the patient is 7.38, it's a acidotic process, right? If the PCO2 is 40, that's perfect. But if it's in this range, it's still normal, as is this range, still normal. But it's going to be on the range of, a respiratory component or not. And then the bicarb should ideally be 24. And if it's in this range, that's acceptable. But it's going to be on the side. Unless it's 24, it's going to be on the metabolic side or not. Okay? That's how that works. So now, lastly, for this section, I just want you to think about acidosis and alkalosis. And if you think about what's going on in these conditions, it should make it very clear to you, why it's happening. So think about metabolic acidosis. In metabolic acidosis, well, first of all, when the pH is 7.4, the CO2 is 40, the bicarb is 24, when all of those things are perfectly normal, that's homeostasis, right? Everybody lives together in peace and harmony, and the angels sing, and the birds chirp, and all that. That's perfect. When there's a problem, though, it falls into one of these four categories. If the body is making acid, right? If it's making acid, then that is a metabolic process. Okay? Does that make sense? Well, it makes sense because if I'm making acid from ATN or I'm in shock, for instance, those are reasons that I would have metabolic acidosis, because I'm making acid for some reason. Diarrhea is the most common cause in the outpatient kind of world. But there are some medicines that can do it too, like acetazolamide, spironolactone, one of our anti-aldosterone drugs. So all of these should probably, they should just sort of make sense to you that we're making extra acid for some reason in these conditions. And if you want to memorize them, you can memorize them by memorizing HARDUPS, HARDUPS. Okay. In respiratory acidosis, the CO2 is going up because we're not breathing as much, right? Our respiratory rate has decreased, and or I should say our ventilation has decreased, right? Maybe our respiratory rate has increased, but maybe it's decreased. But if we have pneumonia and there's less gas exchange, then that's going to effectively cause decreased breathing, right? Less gas exchange means there's more CO2 building up, as would happen with an airway obstruction or CNS depression or pulmonary edema. Anything that impairs gas exchange is going to cause hypoventilation. Contrast that with what's going on in respiratory alkalosis, which is blowing off too much CO2. I remember being a kid, I couldn't have been more than 6 or so, and my mom was a nurse, and we went to Hershey Park one night, and somebody was on one of those scary rides and was having a panic attack afterwards. And I remember my mom, now this was in the 1970s, right? And I remember my mom got a paper bag and put it over the person's mouth and helped them to sort of keep more CO2 so that their tingling lips and fingers and their anxiety, it gave them something to concentrate on to slow down their breathing, and doing all that stuff helped them to retain more CO2, and the symptoms improved. The symptoms of respiratory alkalosis, the numbness and tingling and all that jazz. So I just remember that was that paper bag was helping that person to hold on to more CO2. And that's what I remember. So all of these things go along with that. CNS disease, hypoxia, anxiety, having the mechanical ventilator set incorrectly, sepsis, all of those kind of things can cause respiratory alkalosis. Okay. And then that leaves metabolic alkalosis. And actually there was just a case report in the New England Journal a couple of months ago about a licorice death from somebody ingesting only candy, only licorice for a period of several months. And he ended up dying. It was pretty interesting. So you can look that up. Don't eat too much licorice. It's a bad thing. The most commonly seen thing with this metabolic alkalosis is vomiting. You lose too much stomach acid. That causes a metabolic alkalosis, and so vomiting is the thing that you should think of as the major cause of that. Sorry, one last thing. The anion gap is another thing that we need to consider. There's normal gap acidosis. So if you take the sodium and subtract the chloride and the bicarb, you should have a gap that is less than 12. I think it's like 3 to 12 or something like that. So if you have a gap, that is, if the answer you get from this equation is greater than 12, you have a gap acidosis, and you should look for these causes. A gap acidosis is caused frequently by salicylate overdose, ethylene glycol, alcohol, lactic acidosis. All of these cause an anion gap acidosis. That is where the sodium is out of proportion to these other electrolytes in the blood. Okay, so again, you can memorize this if you're so inclined by memorizing cat mud piles. But these are all the different causes, potential causes of anion gap acidosis.